will be recorded. And again, I would like to thank Dr. Moon for joining us today for this most important conversation. Please know that again, if you do not want to be on screen, please feel free to keep your screen closed. If you'd like to ask questions, please use the raise hand function or the chat function. So once again, thank you very much. And I'm going to turn the floor over to Dr. Moon. Thank you.
Thank you, Deborah, for the introduction. Hi, everyone. It's really nice to be here. And thank you for the opportunity to discuss. It's a two-part series, and today is a part one. Discuss the series of two papers that I wrote with my colleague and friend, Dr. Zinzi Bailey. The second, I'll give a plug to the part two event later where she will actually join me. So today, well, I should do an introduction of myself. I am a adjunct associate professor at CUNY's School of Public Health. I am largely a full-time healthcare and public health practitioner. I'm a social epidemiologist by training. I've been teaching at CUNY for the last I think going into 5 years now. And I have been really proud of the resiliency and the robustness of the students in this school program that I've seen. And I'm so honored to be part of the Harlem Health Initiative webinar series today. So this is about, I'm going to talk today about the structural racism and the political economy of COVID-19. This is an article that Dr. Bailey and I wrote back by now a year and a half ago on Journal of Health Politics, Policy and Law. We were commissioned to write this commentary paper, and then we suggested we're going to write about the Bronx. At the time, I was for the past 6 years or so, I was working as part of New York statewide Medicaid transformation work, and my office was in the Bronx at SPH, St. Barnabas Hospital health system, right in front of or behind, depending on how you look at it, from Arthur Avenue, that's South Bronx. So the Bronx has a very dear place in my heart. So we wrote a case study on the Bronx in terms of structural racism and COVID-19, and we basically wrote it over a weekend, and it went live online. I think it was like late May or June 2020, and then it came in print in November, December timeframe. So we're going to talk about that paper today. Hopefully this will give a bit of a structure in what's written in the paper, and I'm guessing you have the access to the article. So next slide, Claire, please. Thank you, Claire, for driving the slides. So really quickly, these are the numbers we're very familiar with. Just to take a stock of what's been going on as of today, November 17, 2021. Globally, we have 254 million cases, US 47.3. Number of confirmed deaths, as you see, globally 5.11 million and US 765K, and numbers still increasing, even with the vaccines. Couple of points to make. One, US accounts for 4% about of the world population. If you look at these numbers, US accounts for 19% of the cases, total cases. That's disproportionate, to say the least, and 15% of the world global deaths by COVID-19. So this is a nice introduction to set the ground for us to talk about, disproportionate health inequity in the US. And the other thing I do want to point out, and this is really not, I'm not discussing other epidemics at this talk, but I want you to note that HIV/AIDS, which was, which it was a pandemic and now it's, chronic disease, we still live with it without the vaccine. We had worldwide 76 million cases, almost half of them, 35 million have died. So that's a really big number that's still going on. So that's a number that I would like you to know. Next slide. So speaking of inequity and disproportionate numbers, so there are holes in the playing field. The COVID-19 has not spread, on level playing field, as we have been discussing amply as a country since year and a half, almost 2 years ago. So these are, the bullets of, like what those holes might be. Racial ethnic minorities, that includes, the BIPOC, right? Black, Latinx, Indigenous, and Asian, poor people, low income population, elderly people, people living in rural frontier areas, and that also includes Native Americans as well, people experiencing homelessness, essential and frontline workers. That's a large focus of the Bronx case that we're going to talk about today. People with disabilities, people who are, justice involved, as in incarcerated in our U.S. Criminal justice system, and people who are not born in the U.S. and migrants. Next slide. So this article in New York Times came out right before our people came out. So basically talking about the death towers. These are the public housing buildings in the South Bronx that, the residents of which we worked with at my work. And the article talks about, what it says, the virus hotspot. It talks about the lack of PPEs and, lack of access to care and testing, and all of them are true. But the article also has a very cross-sectional static images of what's going on in the most recent responses in the Bronx, which without the historical and racialized context, it really misses the point. So that's what we're going to talk about, and that's what the article talks about. Next slide. So this map, you guys, a lot of you might have seen this. So these are the 4 color maps juxtaposed. So number of positive cases, you can see darker color obviously is a higher number. But then if you look at the service workers concentration, rent burdened households, meaning like people who don't have enough money to pay rent, people of color, Black and brown largely, they kind of all look similar. Western Queens as well as the Bronx have 35+% service workers. That's twice and 3 times more than other boroughs, and 61% rent burdened. And Western Queens is the 3rd most crowded neighborhood. Bronx is number 1. And Bronx also has the highest concentration of public housing. So racially, economically segregated. The key word here, segregated neighborhoods are the hardest hit in New York City. So I want you to remember this map, this image. We're going to come back to this. Next slide. And why does it matter? Why am I upset? I was about the New York Times article, because the prescription of for the cure rests with the accurate diagnosis of the disease. There's a medical history in someone with the disease. We have a historical context we need to put this in to look at so that we can actually correct it. That's a quote by Martin Luther King Jr. Next slide. So this graphic depicts if the goal is health equity, so all the way on the right side, that's a downstream, the most proximal end of our goal, health and health inequities, or equities rather, that's the goal, right? So we talked a lot about, risk factors, pre-existing conditions of COVID-19, what disease and how it went down for those who were infected and who died, all important. And that's what New York Times article focuses on. But then one step further, further upstream, one step further distal, that's because of living conditions. People who they have certain jobs and work environment that was so conducive for them to be infected, and then they go home to a crowded housing and they give it to their family members, people who they live with, oftentimes multiple family units, and so on and so forth. So, having, no access to care and healthcare and PPE, absolutely important, but there's more to the story. So that's when we're talking about social determinants of health, like, housing condition, right? Food insecurity, childcare, the job benefit, things like that, like sick days, those are social determinants of health. One step further, if you look at the left, right, left 2 squares, we're talking about social determinants of health, the inequities. So there's a reason why. So if you can ask questions of why health and health inequities, why such risk factors, why such living conditions. So there is this public sector, private sector, multi-sector operating in the same space in constituting institutional inequities. And then that also, one step further, all the way to the, upstream, there's a social inequities that is created by, our societal racism, sexism, classism, heterosexism, isms, etc. Next slide. So structural racism is defined. I think that often people confuse the institutional racism with structural racism. Institutional racism, interpersonal racism, internalized racism, all are at play multiply mutually reinforcing way, and that's the definition of structural racism. So structural racism is defined as the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, healthcare, criminal justice system, etc. We're going to talk about that in a bit. So within the structural racism framework, there's a pathway, that goes, we just saw, right, from social, the health inequities coming from social determinants of health, that comes from social determinants of health equity, and these inequities in health are racialized, and it's by racialized groups, and we're going to see that in the Bronx. Next slide. It's another way of organizing the key components of structural racism. So mutually reinforcing, like I said, inequitable systems and institutions in different sectors. So it's not just, one sector, it's, many. So, and then there's the different levels and vertically, right? Institutional, interpersonal, individually. I just said those things, and it's different ways of looking at it. So that leads to, in the end, it normalizes and legitimizes historical, cultural, institutional, and chronic adverse outcomes for people of color. What does that mean? People of color tend to have, more higher prevalence of hypertension. That's a very racialized statement. That makes it normalized, for the people of color, for such a condition. Or legitimate, that just, is that a genetic thing? So that's, we're gonna talk about that a little bit here. Next slide. So mutually reinforcing mechanisms, of the multiple sectors here. So we're going to talk about redlining. If you haven't heard of this, the term redlining is, it's in the housing. It's a segregational housing system. That is, that's the most prominent example. That's the most prominent and foundational system that we have had to reinforce the structural racism. So then that, in conjunction with tax-based school funding. So, school quality, what happens, schools in the US law, school funding comes from the tax base. So, depending on what neighborhood. So the better neighborhood, the better school. And there's a reason for that, right? And then, and in conjunction with the Social Security Act, not the 1965 amendment, but Social Security Act of 1935, where, that's part of the New Deal era, coming out of our Great Depression era, to make our, social welfare system more robust. But that was really mostly for the, white population. This is also, at the same time when, Jim Crow era was deeply in the US. So that time in the 1930s, so the Social Security Act, systematically discriminated people of color. So what happens? The differentials are created in intergenerational wealth, education, and income. Why is it intergenerational? Obviously, the housing quality, neighborhood quality is really directly related to school funding. So that's for our children, right? The school quality is bad, then what happens? So it's an intergenerational exposure to these inequities, and then concentrated poverty, therefore, and also quality or poor quality, rather, hospitals and schools and jobs and all other things that is, across generations, over the life course of one's life course, and across domains, across different systems. Next slide. So coming back to COVID-19, let's talk about the basics. And you guys all know this. The real drivers are places in the settings: close living quarters, close working quarters, large indoor gatherings, and the lack of access to hygiene and personal space, disinvested and segregated neighborhoods. I want to talk about the word disinvestment. Disinvestment is not the same as lack of investment. Disinvestment means, one actively takes out, diverts the investment in one neighborhood into another. So it's pulling out the money as opposed to just leaving it alone. Leaving it alone, doing nothing, abandoning is bad enough. But disinvestment is something more intentional, more proactive. So next slide. So that's the social determinants of health. So next, this slide shows social determinants of health inequity. So why those, closed living quarters and working quarters, why all those things happen? The risk factors, because the real drivers are the places and settings and not people's characteristics and comorbidities. So state mandated racial ethnic segregation and subsequent disinvestment. I just unpacked the term for us. Territorial stigmatization, so that again has a lot to do with the indigenous population, among others. Racialized dismantling of the American safety net, we'll talk about that in a bit. Anti-immigrant sentiments, anti-Black racism, and racial capitalism. We're going to talk a lot more about racial capitalism in the part 2 of the talk. Next slide. So this is a quote by Mandela's daughter, Zinzi Mandela. Racism is not an event. It is a progress. It's a long-standing process that's been in place in our country's history. Next slide. So 1946 Hill-Burton Act included separate and equal treatment of white and people of color. It's in fact, separate and unequal. And the most prominent example, and one that is most foundational of all of our systemic and structural racism, is with the racial residential segregation of the United States. So you see on the right side, see these the color maps, and you see maybe you can read it. Green is best, blue still desirable, yellow definitely declining, red hazardous. And I'm going to explain what that is. Next slide. So on the right side, now we're getting into the case study of the Bronx. The map on the right side is the map of the Bronx. The red is where my office, the St. Barnabas Hospital and the SPH health system is. And my office is right there, and that's the red. Next slide. So after the post-Great Depression in the 1930s, Federal Housing Administration created HOLC, which is a homeowners loan corporation, to offer mortgage loans to people to buy homes and promote neighborhood developments. So they graded in these 4 risk categories of 250 plus cities in the U.S. and A, B, C, and D. I just read them through. And for the D, the red is basically, that's the redlining. Literally, it just got the red lining around the the neighborhoods, and it's essentially ineligible for Federal Housing Administration's mortgage loans. And the quote is from the federal documentation. This was formerly a good white residential street, but Negroes, not my words, I'm quoting it, are gradually taking up the area. So that qualified as a D, hazardous. And HOLC recruited, mortgage lenders, developers, and real estate appraisers to create, these maps, and also, getting these entities to get involved in developing, developing neighborhoods and housing, and basically, wealth in the American people. Next slide. So back to the Bronx map. These are again straight from the federal documentation. There is a steady infiltration of Negro, Spanish, and Puerto Ricans into the area. So that's the reason why it was redlined. Next slide. So that's so again, just showing you, and there's also, Italians, Sicilians, Arthur Avenue, if you know where that is. So that's sort of, that's the area where, the first wave of Eastern European and Mediterranean immigrants came to this country. And so Italians and Negro were also infiltrated in this areas. So that was also redlined. So, and then next slide. Fast forward, if you look at, this is the actual data from Montefiore clinical data. If you look at the folks who live in the red line zones and who did not, so A, best, all the way to D, hazardous. If you look at the obesity prevalence, it's not quite double, but almost. And the number also in the hazardous area, there's a lot more who live in there than the best. So that is one dimension, one consequence we can see from data that the overall disinvestment has led to the less resources, right? So what happens in the neighborhood when there's an active disinvestment of development money, financial backings and investments. So the school, there's no school, property taxes low, right? Because the housing is horrible. School's bad. Any fresh food and quality food outlets will not come in because they know they're not going to make money there, right? And then so healthy food gone, safe and green public spaces, clean streets, quality, all of them will be devoided in this area. So that leads to, obesity prevalence, among other things, which is, behaviorally related, not individually, but, it's not, for the most part, obesity prevalence come from, the contextual and the behavioral factors as opposed to genetic. Next slide. Another map. So redlining, if you look at the left side, this is the residential structure, that's rated as fair or poor. And then on the right side is the children asthma hospitalization. They're pretty much the same. Claire, if you don't mind going back to slide 5, remember this image where the red is? Here, again, look at the Bronx area. It's the same. So number of positive cases, service workers, housing, rent burn households also goes, directly with housing quality and people of color. Back to slide 20. Thank you, Claire. So are we really shocked? Should the New York Times article be so shocked that, that the burning tower and the virus hotspot was the Bronx? Coronavirus is just bringing this to the fore to make this case obvious, the results of this decades-long disinvestment and racialized systemic policies. The next slide. So then what happened? Many of you may have heard, the Bronx burning, the Bronx fire in the 70s, leading into 70s. So that didn't help in poor housing and the home ownership and homelessness problems here. So what happened is because it was such a disinvested area and there's rats and roaches infested, really poor ventilation. I mean, I see it. To date we see that. So then landlords would because they there's not a lot of investment at all. So landlords are not getting any tax benefits or any benefits of any kind for fixing up, actually putting in the money to improve the quality of these housing. So what they did is they would kind of basically set this building on fire, literally. So that the fire insurance money, so they can recoup their costs from the fire insurance money, and that kept happening. It became this fire epidemic in the Bronx, and then coming to the 70s, the peak level of the fire was in the 70s, and that's also coincidentally the same time that New York City had we filed a bankruptcy in the 70s, and this is like the other time, last time that I think 500,000 residents left New York City and never came back. This is a really bad time for New York. So then what the city did, Mayor Lindsay hired Rand Corporation, which is basically a white shoe consulting firm who used racially biased algorithm to figure out where they will cut the city public, investments. So, things like the firefighters, sanitation, school, education, those funds are being cut. And a prominent area, one of the prominent areas that these fundings got cut disproportionately was the Bronx. So then fires are already happening, and then the firefighter, I think something it's in the article. 7 out of how many? 206. 7 out of 13 fire stations in the Bronx closed because as a result of this Rand Corporation analysis. So at one point in the late 70s, the fatalities quadrupled, and people, like half the population basically, and half the buildings got burnt in the Bronx. So that's really, really devastating. So then New York City did not get the federal bailout by President Gerald Ford either, and he called the public spending and public services, including public schools and sanitation, all that I mentioned. He called it the insidious disease, the public funding. So the New York City was in a really bad place, and the Bronx even worse. And then fast forward a little bit, in the 80s, there's further cut by President Reagan in a social safety net. So Medicaid and SSI, things like that. So then the following is following ensued the crack epidemics, and as we know, all the horrible things that happened in Harlem and the Bronx ensued in the 80s. So that's the history of the Bronx. And that brings us back, that brings us to date, 2019 and 2020 COVID-19 pandemic. And nobody should be surprised at all that, we have seen what we've seen in the Bronx. Next slide. So deep inequities, as we've seen, as shown by the Bronx case study, make us more vulnerable for the next pandemic. I hope it's very, very obvious for us to, see that. That doesn't mean that we don't repeat the same mistakes as we have in human history. Again, at the very distal, very foundational part of our U.S. history is based on racial capitalism, structural racism, classism. And on top of that, we did see a lot of organizations and foundations and individuals who have stepped up. But there's a lot of, self-congratulation, we say in the article. And, it doesn't, again, if we look at the cross-section, cross-picture, what's happening right now, and just, giving handouts or, giving like food pantry type of support, we're not really fixing anything fundamentally. Like we cannot negate the need for investment in the fundamental system. So going back to normal means these people, people who have been disadvantaged for decades will be dying again. So going back to normal is not an option. I know this is already a year and a half ago we wrote it, but I don't really think that I see a lot of difference yet. We're still not quite out of the woods, right? And we're getting better. Vaccine uptake, and now children, and we'll see what happens this winter. Things look a little better. We might be able to, be seeing the end of the tunnel, but we don't know yet. So I think that we're still grappling with what we need to be doing tomorrow and today. Are we thinking about next one? There's gonna be next pandemic. I'm not the only one who's saying this, but I promise that's going to happen. So then what's going to happen to us is the question at hand that we as our future leaders, and future is here. So our leaders right now, all of you need to think about. Next slide. So, the next article that I'm going to discuss at the part 2 of our conversation, we go in much more specific details of the recommendations. But in reimagining the economy in our nation, we talk about truly affordable housing, security not based in jails and prisons, but quality schools and community health services, and public health and social service infrastructure to be bolstered, and all workers living wage and guaranteed a living wage and occupational protections, as opposed to big corporations like Amazon and Apple making how many more times than normal profit, and their workers are still lacking all these things. Also invest in our local health departments, the New York City Department of Health and Hygiene. That next slide, and that also goes all the way to our CBC, independent and well-funded CBC that's always functioning. We saw how we literally suffer from underinvested CBC not functioning as it should have been in the very first few months. And I really think that those first few months could have been definitive, and what trajectory we got on at the beginning, at the get-go of the pandemic, and look where we are, right? And invest more in healthcare for all that is not based on full-time employment as it is in this country. So on and so forth. But really the last time, invest in public physical and mental health. And, because of mental health needs and, taking care of all the trauma and casualties, if you will, injuries physically and mentally and behaviorally, that's going to be our immediate, intermediate term task after we get over, after, we come out of the woods, kind of. So invest in all those things, physical and mental health, and transform our places and policies that are breeding grounds of inequities, as we have seen, these, multiply and mutually reinforcing systems. Next slide. So this is a quote, my favorite. This was my quote in my thesis book. Rudolf Virchow, he's 19th century or 19th to turn of 20th century German physician. He was a medical doctor. He was also a pathologist. He's actually the father of modern pathology, and anthropologist, and then he's the founder, we say, of social medicine. He's the one who, and so we've known, public health professionals known, not just in the last few years, we've known for at least for 100+ years, that public health is rooted in social justice. And it's, advocating for our joint interconnected humanity is our job. So, and this is his quote: medicine is a social science and politics is nothing but medicine at a larger scale. So thinking about investing in existing, capable, and dedicated community leaders who are already working, who have been working, and join forces to strengthen what we got, to coming together because we're interconnected. Like the adage of you cough and I catch cold has never been so literally viscerally true, right? So thinking about all of that, this is a call for all of us to think about how we can work with the community, existing resources, existing assets, to get to the the root of our societal problems, and then start improving it from there, not just looking at the proximal, the most downstream phenomenon, so that we can prepare for the next pandemic. Next slide, last slide. So part 2 talk, I'm just going to give a little plug. There's a link to the article. It's free access for all, and in fact, it's a AFT, that's American Federation of Teachers. It's a sister organization of AFL-CIO. So we wrote a feature article for their fall issue of their journal, which is called AFT Healthcare. So that's the part 2 called the part 2 talk is called COVID-19 and Political Economy, Investing in Our Collective Future. So it's December 8th, and Dr. Bailey and I will join to talk about what we wrote in the article, which includes racialized drug policies. So we compare, it's a case study to compare crack epidemics and opioid epidemic, and how the racialized and the colored lens we have cause the two epidemics to totally fare differently. And also, racial capitalism, our capitalist society is based on the racism, and post-colonial recruitment of healthcare workers, including Filipino nurses, and sort of a foundational racism against Asians and immigrants. We have a case study on the two. So I hope that the article, and I think it's near jargon free. So I hope you guys get to read the article and bring back questions and comments so we can have a active discussion. So I think that's the last one. Yeah, thank you. Thank you so much.
Dr. Moon, that was, you've left me speechless. I put the link to the article and the link for the next webinar, so please feel free to register, but I also want to be able to open the floor for any questions or comments. Please feel free to either raise your hand or put the questions in the chat. Excellent information. This dovetails with defunding movement and reallocation of assets from police force to public health. You've got a bunch of, let's see, there's another, thank you for the wonderful presentation. And I see, Francisco, would you like to unmute and ask your question?
Yes, good afternoon, everyone.
Good afternoon.
Yeah.
It's a comment. It's a comment to Dr. Moon.
Please.
Although I came late to the webinar, but I really appreciate this information. It was a rich webinar. I hope next time when you're on, I would have time to watch you entirely. Thank you so much. Thank you so much. You know what? The world needs to watch your webinar. The entire American society need to watch your webinar. Thank you so much.
She's absolutely right. That's right. She's absolutely right. It's a wonderful, wonderful.
There's a comment I want to, so did the closing of hospitals in the Bronx affect the ability to respond to the COVID pandemic? That's a complicated question. Anytime we close, hospitals, yes, and yes, because our healthcare system is very hospital driven and hospital based, and that the pandemic was operated entirely on an emergency medicine case, right? So people went to the emergency room. We didn't have anything. We didn't even have masks, right? So primary care doctors and community health centers, testing, like all those functions were not equipped. We did not have a procedure, policy and procedure in the playbook to really reposition all the healthcare workers to do their job. So yes, because our system is hospital-based. No, because there are other functioning other parts of the healthcare system that should have functioned differently than we have. So maybe some other countries who responded really, really well to the pandemic. It was say South Korea or Singapore, Hong Kong. It was the CDC, the government, that work with, they really trained really quickly all the way down to the local health department. So in our case, that would be New York City Health, health department and mental hygiene. And they contact traced, they deliver food. They had people deliver food to those who are quarantined and isolated. They took care of the individual. That's not a hospital job. Hospital job got so big because everybody was literally dying. We had to, bring the ambulance and then bring them into the emergency room, and look how well we did, especially in places like Elmhurst, Queens, and the Bronx, right? So that's a very complicated answer I just gave you.
So I have another question here. Do you have information on the occupations of people in the Bronx? Can you talk more about the role of people from the Bronx as essential workers?
So yeah, I think if I understand the question right, the service workers meaning, restaurant workers, meal delivery people, people who work in the supermarket, or even like meat packing, meat processing factories, and healthcare workers, of course. The service worker, healthcare workers, I mean, not necessarily doctors, not even nurses. I'm talking about really frontline people. So the Bronx and Western Queens have a disproportionate number, percentage of people in those jobs. So that's so you can imagine, they didn't have the luxury to call in sick. They had to work, they had to feed their family, and the kids are home. Kids are hungry, they're all home, so it's really crowded. The likelihood of one getting infected from COVID indoors versus the outdoors, last year we said 19 times more. So that's almost 20 times more. So that's how it all went down. So it's, again, multiple mutually reinforcing factors and systems working together. I hope that answers your question.
Thank you. Alexander, would you like to unmute and ask your question?
Yes, thank you so much. I have a question. First of all, thank you, Dr. Moon. And I have a question about disinvestment. You're talking about literally redirecting money from, one neighborhood to another. And I'm wondering sort of like where is that decision being made and by who? When we're talking about specifically New York City and now, where is that happening and how are people justifying that from a legal standpoint?
Well, in history, this investment decision, the housing was it's a federal housing administration, right? So that comes from federal, but then that trickles down to the city level. So for example, like Cross Bronx Highway, Robert Moses, that basically tore apart the vibrant, Bronx once was a very vibrant, multi-ethnic community, and the highway just kind of totally cut right into the middle of it, so that there's a road straight into the suburbs that was blooming, with all this housing and the A, B, neighborhoods, building all these homes. So that's a city decision. That's, so it goes from federal and then it trickles down to state and city. So it's all of it. I mean, that's the history, and I know that goes on all the time. So yeah, but specifically housing example, that's how it went down.
Thank you.
Evelyn Evans, would you like to unmute, please?
Yes, hello, how are you? Excellent information. I couldn't, but it was a lot of stuff going on in my head. As a teenager, I used to hear this red zoning with my parents' home, and then eventually their house went into foreclosure. We lived in the Bronx on 663 Casanova Street. And I'm just, a lot of stuff is going on in my head. I live at 135th Street and near 135th Street. And I just noticed that about a week or 2 weeks ago, they had a fire, which was a row of fires that had engulfed that whole row, that section there. And also the people that had stands on the outside that sold fruits and stuff, they had a relationship. And I'm wondering, where is all of this stuff going? Because not a year ago, there was some protesters outside of the Lenox Terrace. And, word is that the Lenox Terrace is a very, how can I say, a place where people, it's almost like a land grabber. It has potential there. And when I saw first, it started off with the corner store some years ago. That it was a pancake place, Pam's, and then now I see this row of fires that have almost completely destroyed that. It makes me think about what the doctor was saying. What's going on?
Oh,
We're not hearing her.
I got muted. I'm sorry. I'm not really sure. I know that to date, the Bronx has fewer public service things for everything than other places, and we have more of toxic things like bus depot, things that really that the Manhattan residents don't want. It goes up to the Bronx. So I know that. So I'm not really sure. However, the current fire situation, if it's a phenomenon, or if it's because we lack the fire department forces there. But I do want to point out that some of you might remember there was a conversation about cutting sanitation services in the heat of the pandemic. In the Midtown, there's this boutique hotels are turned into the homeless residences, temporary residences, and then like barricades are built up and sanitation stopped going in there to clean. So that's just an example. I'm just gonna say like that's a time that we need to do more, not less. But the disinvestment, so in the smaller case, disinvestment has happened. It happens time and again. And frankly put, it's like when you make this, it's like homeless people and the others. Who should we care more? That's how it works out, right? But public health, by definition, we promote public good, and public good meaning, if one is better off, we're all better off, right? So it's a very different framework and lens that we need to have. And in the end, look what happened to our community as a whole by having these deep inequities.
Dr. Moon, we have another question. Harlem is struggling with the way needs assessments of its health needs are conducted at the state and city level. Can you say more about changing need assessment protocols and community health profiles?
Sylvie, can you say a little more about what you mean by struggling with the ways the needs assessment are conducted? I just would like to understand what you mean better.
So her comment is, can we change the unit of analysis from individual patients to collective health indicators that are not aggregated of the census data, environmental costs of specific health infrastructure itself?
So if that's that data collection and the way we look at data are absolutely racialized, and that is researchers do it, governments do it. So that's really true. Units of analysis need to change. Yes, I agree. And also looking at the data to be not racialized. We also say decolonizing the data, right? Whose data matters? Thinking about thinking through those things in conducting communities assessment need to change. Absolutely. I think that's a much longer conversation, but we do need the individual level, longitudinal, individual, not cross-sectional, but longitudinal meaning over time, data of individual, not necessarily just patients, but if we have the data of the patients, we need to be able to link it to, the other non-clinical aspects of the data as well. And of course, we need the aggregate level, like a neighborhood level data, right? I think it's being done. It's definitely being looked at. But in terms of analyzing, when it comes to analyzing and putting the data together, disparate data together to make sense of it, I think that's where more often than not, it gets, racialized, intentionally or unintentionally. So yes, I do agree. I'm not sure what I'm just thinking what needs to be done. Who needs to do this? Well, that's your job.
There's another question here. Do you know if contact tracing has led to information on places that led to high rates of transmission? An example was the Bronx Terminal Market, a place with many infected workers, 2 fare zones for MTA. Are there meatpacking or other food processing areas in the Bronx?
I think that contact tracing definitely gave more data on this. But I think it's also like this is if we're talking about aerial, like a geographic places to look at the prevalence. I think it's like the maps I've shown you. There are those too, and there's also like mobility data, like using like your cell phone data to see like how much movement has happened in what borough and what zip codes. Contact tracing, I want to say, I mean, I yes, but contact tracing in this country and including New York City had just not. We got started a little late, and by the time we got started, the infection, the transmission was so rapid, and it was sort of, like it was a bit of a mess, for us to really get to it, like South Korea did at the beginning, like first month, right? That's very different because COVID-19 is a, airborne disease, and it's a really, really hard to trace the contacts, and we don't have the infrastructure and the kind of notion of privacy in our country. Right? I mean, people have a hard enough time wearing masks, right? Like, or like giving up their data, much less. So in an ideal setting, contact tracing would have a lot more information that one can glean into, but I'm not really sure how much of that came out of our contact tracing situation.
Got you. You have another question here. Do you know if the use of public transportation by people from the Bronx affected COVID rates?
Well, I'm not really sure. Well, the thing about probably, I don't know, because we had such disparate infection rates and death rates, and also vaccination rate, and there's no borders between these boroughs, right? So people live in the Bronx, work in Manhattan, so I am sure, but I'm not really sure if I can point out to one a specific data for that, but I'm guessing yes.
Got you. Sylvia's asking, can you tell us who at SUNY addresses health policy and responds to unhealthy? I think as an academic institution, looking at public health as a collective, we all are looking at social and racial injustices through a multitude of lens, not just from a research perspective, but really looking at ways in which we can use our data to begin to impact and continue to change legislation that supports healthier communities and really supports the infrastructure of communities in a way that destigmatizes how people receive and ask for care.
And yes, and at CUNY, yes, absolutely. Some of the ones that I know well includes, Dr. Nicholas Freudenberg's and Nevin Cohen, Doctors Freudenberg and Cohen's Food Policy Institute. So we look at, food insecurity and the CUNY system as well as the city. And then Dr. Scott Ratson doing, I'm forgetting the name of the initiative, the vaccination.
So
the city.
it's the actually CONVINCE, which is the international work around COVID, and then the New York Vaccine Literacy Campaign, where we are working with community-based organizations and associations to provide them with science-based, culturally competent, linguistically sensitive information that they can share with the communities that they serve.
Thank you. And also Dr. Victoria knows mental health, CUNY Institute of Mental Health. She's been conducting primary data research on the impact of COVID pandemic, shorter term and longer term. And I believe it's a longitudinal study. She continues to be doing it. So yeah, the list kind of goes on. The CUNY is an amazing institution with all this efforts going on. And I'm sure someone that have come to this talk series, but yes.
Yes, and that Dr. No is working on a project called Harlem Strong, which is really looking at mental health and the impact of COVID in doing some task shifting so that more people are aware of mental health issues, and there'll be some mapping going on. So there is one thing that we can say about this School of Public Health is that we are community centered, and these initiatives really came from community. You have another question here. Do you know anything at factors related to immigration and fears of undocumented residents affecting COVID transmission, treatment, and access to social determinants of health?
I mean, obviously, yes. Undocumented, a lot of them are in service work environment, and migrants work in, service work, it's some of the most insidious environments, such as, meat processing factories and things like that. So absolutely. Do we have very accurate data? Probably not. The data is probably, underreporting because of the nature of the undocumented residents, but absolutely.
So we are just a minute out from our 12:30 mark. I wanted to give Dr. Moon an opportunity to bring us some closing thoughts. And you'll see also in the link, I have included the link for the December 8th webinar that we hope you will come and join us. I'm putting that in again. At the conclusion of this, you will also receive a copy of this recording. It will also live on the SUNY School of Public Health and Health Policies Harlem Health Initiative YouTube channel. So you can always feel free to come back and share this information. So Dr. Moon, would you give us your parting thoughts?
I'm going to share my email address in the chat as well. If there's anybody with any questions, I'm happy to address it as, or direct you to the right sources and contacts as best as I could. I know that we've been suffering as a society with, suffering from structural racism and anti-Asian, crime. That's like a preview for the next the article. and George Floyd, but the truth is George Floyd, how many George Floyds have we had? Like, that this is not the first time in our history that's happened. My point is, this is that time. This is a very important seminal time that these issues are crystallizing in our society. It's in our faces. We cannot ignore it. So that is part of human progress. Pandemics are, what we've seen is horrible, some more horrible for some people than others. But this also affords us an opportunity to really think deeply about what is the significance of what we're seeing. What can we do about it? So I hope that we are all grappling with this in this opportunity that we have. And thank you again for having me, Harlem Health Initiative.
It is truly an honor and a privilege. As I said, at the end of this, we will be sending out not only the link of this recording, but also the registration for the December 8th webinar. So if you didn't get it in the chat, please have no fear. We will definitely be sending this out. You are getting nothing but kudos, lots of thank yous for your work, Dr. Moon. And we will also share the presentation in the PowerPoint. Lots of excellent sessions, Dr. Moon. I think I talk about this conversation all the time, and I think I have my talking points, but you have just added more to that. So once again, on behalf of the community, we thank you for your time, your energy, and your talents, and we look forward to seeing you all on December 8th. Thank you again, and have a great day.
Thank you.